Hello and good morning, rather good afternoon, everybody. I am Dr. Himanshu Mathur on behalf of Jaipur Rehab. I welcome you all for the first ever free online classes on biomechanics. So we are here to start with our first module, that is the biomechanics of the hip joint. I know you must be waiting for a really long while, and we took a little while to start off with this venture. So this was one of my dream ventures, which eventually happened by this time in the lockdown. So let us try to inculcate few concepts of biomechanics within. We'll be sharing some good concepts about it. Okay, so let me not waste any time. And there are a lot of people who are waiting for this also. They have come live. Hello, everybody who have come live for this session. And let's start with this. Okay. Before starting from the hip joint, I would rather start from the basic concepts of the biomechanics. All right. Okay. If you people can see my window. Great. So we'll be starting with levers in human body and the concept of torque. Before I start the concept of levers, I'll rather tell you something about the torque. Eventually, when we talk about the torque and the movement within the human body, all the movement that occurs within the human body at every joint requires torque. Torque ka matlab kya? What does torque eventually means? Whenever you try to read out it from books, it's a little complicated thing which is given inside that books or written in the book. Okay, so to make it a little simpler for you people, I would just like to say a very simple line that you people, everybody who's listening to me, you must be knowing that the movement occurring at the joint is an angular motion, right? We have a range of motion for this, right? And the range of motion is calculated in terms of degree. The unit of range of motion is degree. So if it is a degree movement, it is a range and it is an angular motion. So the force that is required to carry out or to generate an angular motion is torque. So every movement that I am doing at the joint is an angular motion that requires an angular force, and that angular force is torque. Simple as that. All right, let us move forward in this. So this is about the movement. Life is all about the movement. We have to stay connected with the movement, and movement requires torque. All right. So I'll try to go a little more forward, and let us now talk about the concept of lever. Every joint that generate movement in our body are levers. Okay. To be more simplified, let me talk a little about the concept of levers. Okay. Let me first start with the pointers. So whenever we talk about this, suppose this is a small line, and the point which is pivoted somewhere is your fulcrum. Okay. At one side you have effort, and on the other side you have weight. Okay. Now, if I talk about the constitutional definition of the lever, so the lever says it is a rigid bar which is pivoted at one point and has a capability of movement. Suppose, मान लो, I'll be going in both Hindi and English. Okay. मान लो ये एक object है. Okay, if you can see that, ये कहीं से भी बंधा हुआ नहीं है, pivoted नहीं है. अगर मैंने इसको धक्का मारा, if I'm pushing it from somewhere, it will go into motion, right? The movement will occur in the whole body, which eventually becomes your linear motion. But for torques and for the joints, we do not talk about the linear motion. We are talking about the angular motion. So if this object, or if this rod, or if this bar is pivoted, मैंने कील से ठोक दिया इसको एक जगह से, ठीक है ना? I have pivoted one point of it. So I have pivoted it from one point, so the other end is free to move. Or if I have pivoted it from center, both the ends are free to move here. All right. So if both the ends are free to move here, it is moving at an angle. At certain angle, it is moving, right? If it is moving at a certain angle, it becomes your angular motion. Okay. And angular motion requires torque. All right. So let me tell you a few more things about it. Now, we have here is the structure of your lever. This is how a lever appears to be. Okay, so we have a force in between, we have a fulcrum, I'm sorry, in between. Here we have a load is the resistance, okay, or the weight, that is what we talk about. And we have a force here. Force is the effort that we apply. All right, now the major thing that comes to us is the wait. Okay, now the major thing that comes to us is the moment arms and the weight arm and the effort arm. The concept of the weight arms and the effort arm. Everybody of us who have studied levers in the first year of their bachelor's of physiotherapy, they must be knowing the concept of the weight arm and the effort arm. Now let us calculate it along with the help of the torque. Okay, let me move a little ahead. We have talked about the concept of torque. Okay, now to move forward and let us correlate levers with torque, you must be knowing the formula of torque. Anybody, you can write it in the comment box. Do you know what is the formula of torque? What is the formula of torque? Do you know that? Anybody, you can write it in the comment box. I'm able to see that. All right, I'll tell you. The formula of torque is this, that is, torque is equals to force into the perpendicular distance. Now this force, when I talk about the movement occurring at the joint, if I'm talking about the human body movement, then this force is the force applied by the contraction of the muscle. So this is the muscle force. Okay, I can also tell this, or I can also call this as my internal force. Okay, now that becomes the effort that I was talking about in the lever. Okay, the internal forces that are occurring within the body. And always remember, I'll be talking throughout all the joints that I'll be covering in this biomechanics classes. When I'll be talking about the force or the internal force, that will only be the force or by the contraction of the muscles. Okay. Other than that, the forces which are created by the body weight, the forces which are created by gravity, the forces which are employed by as a ground reaction force, the forces which are employed by any other resistance which is being kept on the limb or somewhere else, they will all be considered as an external force. So we have only one internal force that we'll be talking about here during the analysis of forces, that we'll be talking about during the different sessions. So during the analysis of forces, whenever I'll say internal torque or internal force, that will always be by the contraction of the muscle, or that will be the muscle force. So if I'm talking about the internal force, the torque eventually becomes the internal torque. Okay, there can be internal torque also, there can be external torque also, so as to make the lever at equilibrium. All right, if I am standing in a static position, in a what you can say stable equilibrium position, my external forces or external torques are equal and opposite to the internal torques. So if there are some external torques, there are some internal torques also. Okay, to maintain my head in an erect position, what I have to do is my extensors are working against the weight of my head. So I am in equilibrium. So if I am in equilibrium, the forces or the torque generated by the extensors of my neck is equal to the torque generated by the external force, that is the weight of my head. Okay, so I am in equilibrium, and at equilibrium, internal torque will always be equals to the external torque. Okay, and that internal and external torque will tell you about the internal forces also and external forces also. So we are pretty much clear about the concept of torque and the forces. But at the same time, I can see one more thing written here, that is the perpendicular distance. Now, what is this perpendicular distance? This perpendicular distance is also known as momentum. Okay, let me show this to you here. So this perpendicular distance is also known as moment arm. Now, when I talk about the perpendicular distance in the internal force, or the internal torque. So it becomes the distance of fulcrum. Fulcrum will always be your joint from where the axis is passing. Okay, so the distance, the perpendicular distance between the joint and the point of attachment of the muscle which is causing this force or which is generating this force. Okay, so the perpendicular distance between the joint and the site of attachment of that particular muscle which is causing this force will be your internal momentum. Similarly, the distance between the joint and the what you can say, the weight axis of any external force which is being employed, be it your body weight, be it any gravity, be it any other external load which is being kept on the limb. So the line of there, the mechanical axis or the weight axis of that particular load, the distance between the joint axis or the fulcrum and that particular weight will be your external momentum. So multiplication of external force and external momentum will give you external torque, and the multiplication of force with internal force, I mean with internal momentum, will give you internal torque. Okay, this is how you can easily calculate. See, we hardly have cases, or we hardly have so much what you can say of the equipments at our clinical level to evaluate the muscle which is providing us what force that the muscle is providing us. But we know about the what is the by the cadaveric studies. Obviously, we know about the internal momentums. Okay, we can easily know about the external force because it is the external load. We know that, and also we can know about the external momentum, that is the perpendicular distance from the joint. So if we know external momentum, we know external force, we know internal momentum. So out of 4 of these equities, whenever we are in a static equilibrium, out of the 4 equities, we know 3 of them, then we can easily calculate the one equity, that is your internal force. So in that case, we'll be able to calculate that how much force that a particular muscle is employing to maintain a joint in a particular position. In that case, we'll be able to know how much compressive loading a force or a joint is bearing in a particular position. So we'll be enjoying it and we'll be knowing it as soon as we go for some other joint calculations, right? Force calculation. Okay, I'll not be going into types of levers and all that. Okay, because I consider that you people know it very well. All right. So now let us go and start with. I thought I'll be taking say half an hour for this particular thing, but eventually it got finished very early. So now let us come on to the topic that we had to start with. So let us talk about the biomechanics of the hip joint. Hello, that's me. You can see, you can correlate faces. So we are talking here about the biomechanics of the hip joint. Okay, so this is the first part of the biomechanics of hip joint. Everybody, you must be knowing me, so I have a small introduction of my interview here. I'm Dr. Himanshu, Mathur, working as an assistant professor. Sorry, I started a little earlier without introducing myself. I'm working as an assistant professor in the Department of Physiotherapy in Jaipur National University, Jaipur. I'm also working as a chief physiotherapist for my physiotherapy clinics, and I'm also working as a chief physiotherapist and director at Jaipur Rehab. That's where you all people are, and along with this YouTube channel. Okay. So everybody, you must have seen a hip joint. We have a beautiful hip joint. You can see it here. It's rotating all around along with the pelvis. You can see the red colored acetabulum here. It's nothing bloody here, but it's just to make you people visualize the thing. Okay. So hip joint is one of the biggest joints of the body, and it is exposed to extensive load of HAT. HAT is your head, arms, and trunk. Okay, so the weight of the upper body directly falls onto the hip joint before it goes into the lower limb and it dissipates into the ground. All right. So hip joint is one of the very primary joint of the lower limb, which absorbs weight or which helps to transmit the weight. Everybody of you must have studied about the anatomy in your very first years, and you must be knowing about the anatomy of the hip joint as well. So I'll not be taking too much of the anatomy of the hip joint. Rather, I'll be talking more about the biomechanical aspects of the anatomy, okay, which usually books do not cover. I'll try to take up all those things over here. Okay, so hip joint is also known as the coxofemoral joint. Your pelvis has three parts, that is your ilium, ischium and pubis, and it's conjointly it is also known as the innominate bone. Innominate means it doesn't have any name, so the people were not able to name it, so they called it as innominate. Okay, it is also known as cox, so we have this joint is also known as coxofemoral joint. So coxofemoral joint is a diarthroidal joint. It's of ball and socket variety, and it is a very large joint with larger articulating surfaces and very congruent articulating surfaces, right? This the joint you must have seen earlier also, you must have talked about earlier also. So it has a very good articulation, it has a very good congruency. So all those joints that have a good congruency has less motion and more stability. Although hip doesn't have less motion, but this joint is meant more for stability but for the mobility. Okay, this joint is usually being related to the shoulder joint in the upper limb. It is called that it is a corresponding joint of the shoulder joint in the upper limb. But personally saying, I do not agree with that, because although both the joints are the first joint of the appendicular skeleton of the upper limb and the lower limb, and both the joints are ball and socket joints, but at the same time I would just say that the articulation is not the same that we talk about, because the shoulder joint is eventually more concentrated towards the mobility, but the hip joint is concentrated more towards the stability. Okay, we have better congruency in the hip joint, we have lesser congruency in the shoulder joint. Okay, we require more structures for the stability of the shoulder joint. We require relatively less structures for the stability of the hip joint, because the stability is already there by the geometry of the articulation, by the geometry of the bone that we see. Okay, so as I've already talked about, it is a two-segment diarthroidal joint, that is the ball and socket joint, with 3 degrees of freedom. 3 degrees of freedom suggest that it has movement in all the 3 planes. If it has movement in all the 3 planes, it means it has movements in sagittal plane, it has movements in frontal plane, it has movements in transverse plane. So flexion and extension in the sagittal plane, abduction and adduction in the frontal plane, and rotations, internal rotation and external rotations in the transverse plane. Okay, so as the last line of this slide, I already told you that the primary function of the hip joint is to support the weight of head, arms and trunk, that is the upper body, HAT, both in static erect posture and in dynamic posture such as ambulation, running, stair climbing. So weight bearing is a major thing that you have to see it in respect of that. Okay, so the proximal articulating surface or the structure of the hip joint is your acetabulum. So all the 3 bones come and meet in the acetabulum, the ilium, ischium and pubis, and makes a very stable concavity. Okay, although it is more what you can say concave posteriorly, as anterior, the posterior rim is extended more as compared to the anterior rim. But on the contrary, we have more stabilization anteriorly as compared to the posterior also. Okay, so the cup-like concave socket of the hip joint is called the acetabulum and is located on the lateral aspect of the pelvic bone, or the innominate or os coxa. So it lies on the lateral aspect of it. More lateral, a little more directed or oriented anterior, okay, and a little more inferiorly oriented. We'll be talking about the orientation of the acetabulum here. Okay, I've told you that the 3 bones form this. So this, the last line is a pretty much important line when I talk about the hip joint articulation, the proximal articulating surface. Until full ossification of the pelvis occurs between the age of 20 to 25 years, the separate segment of acetabulum may remain visible on the radiograph. So if you take an MRI or a CT scan of the acetabulum before the age of 20, you might see the 3 different bones without any ossification, or you can see the 3 different bones differently. All right. So acetabulum appears to be a hemisphere, but only its upper margin has a true circular contour, and a roundedness of the acetabulum as a whole that decreases with the age. That is because of the ossification that occurs with the age. All right. This is again an important point that I'll be telling you. In actuality, only a horseshoe-shaped portion of the periphery of the acetabulum, that is the lunate surface, we call it as the lunate surface, is covered with hyaline cartilage and is involved in the articulation with the movement. All right, it's not the whole acetabulum that participates or contributes in the movement that we'll be talking about in the movement of the hip joint. It's only a horseshoe-shaped structure that participates in the movement or the articulation in the movement. That is eventually a moon-shaped structure. You can also call it as a lunate surface. Okay, that articulates with the head of femur. Now, this is one of my favorite slides. Whenever you talk about, it is usually being said that we'll talk. We'll be talking about the capsule. So whenever we talk about the articulation of the hip joint, the capsule has a wonderful vacuum inside it, which also gives us a very good amount of static stability and also the dynamic stability of that particular joint. So whenever even we are in swing phase of the gait, then also there is some, say, 13% of the compressive forces that are occurring between the articulating surface. So even when the leg or the foot is off the ground, you have forces that occur between both the articulating surfaces. All right. So 13% of the body weight still exists in the both articulating surfaces. And when I am on the peaks of my stance phase, the forces accentuates or exaggerates till 300% of my body weight. So you can see the range. So it ranges from 13% to 300%. All right. You can see the graph and the picture which is being shown on the right side of the slide here. So if you can see that if the patient is in the if you can see here, so if the patient is in the mid stance phase, the graph eventually rises up. Okay. Then when the patient moves from the mid stance to the toe off, the graph eventually starts to decrease. You can see the forces that occurs, the compressive forces that occurs between the hip joint, the articulating surfaces of the hip joint, the forces eventually starts to decrease here, and they decrease whenever you go into go after toe off. Okay, it eventually vanishes, or they are very less whenever you are in swing phase. All right. So during the stance phase, the lunate surface flattens slightly. So whenever in the stance phase you have compressive loading of the joint, the lunate surface flattens. Earlier it was a horseshoe or a moon-like surface, but whenever there is more compressive loading at the joint, the surface eventually flattens and the notch widens, thereby increasing the contact area and reducing the pressure. Okay, you must be knowing one very important thing, that pressure is equals to force per unit area. So whenever the articulation was only till the lunate surface, the area was less, but the force was the same. That is the HAT that is coming. So pressure is inversely proportional to the area. So if the area is lesser, the pressure would go more. So if the lunate surface doesn't widens or doesn't flattens, and they do not increase the articulating surface area, then the pressure would increase. And this increased pressure would eventually lead to early degeneration of the joint. And that is your osteoarthritis. So if this mechanism was not there, then everybody of us would have had early osteoarthritis of the hip joint. Okay, but eventually we do not have that. Why? Because whenever in the stance phase I put complete weight, that is whenever this 300% of total body weight is being put on the compressive loading is put on the hip joint, the lunate surface flattens and this acetabular notch widens. And if they widens, they increases the surface of articulation or the area of articulation, which eventually reduces the pressure, and at the same time they reduces the chances of getting early degeneration of this joint. Okay, so the forces from the hip may be transferred to the adjoining joints also, that is your sacroiliac joint also or pubic symphysis also. Now, if these joints are incapable of absorbing forces or incapable of transferring forces, or even if they are hypomobile in nature, in that case more forces will accumulate and be absorbed at the hip joint only. Again, this situation will lead to early degeneration. Okay, so to avoid early degeneration, these joints, these pubic symphysis and sacroiliac joint, help to absorb the forces, and they also help being more mobile. They try to dissipate the forces that are coming from the compressive loading of the compressive forces of the hip joint. All right. So let me remove them. What all has been written over here? How to remove it? Okay. All right. Now the orientation of the acetabulum that I was talking about. The opening of the acetabulum is approximately laterally inclined because it has to show its face laterally. So it is inclined laterally at an angle of 50 degrees. Okay. It is anteriorly rotated at an antiversion angle that we'll be talking about at an angle of 20 degrees. And anteriorly tilted also. So it is tilted anteriorly also so as to face the superiorly lying head of the, or to articulate well with the superiorly and posteriorly oriented head of the femur. So it is anteriorly tilted to 20 degrees in the frontal, transverse and sagittal planes respectively. So the frontal plane deviation is 50 degrees. The transverse and sagittal plane deviations are 20 degrees. Each will be talking about them in the very next slide. So the acetabular depth can be measured using an angle. It is called the angle of Weber. So it can be assessed by using a radiograph. So what you do is you connect the lateral rim of the acetabulum with the center of the head of the femur. You can see it here. Can I use it? Yeah, I can. You can see this is the center of the head of femur and this is the lateral rim. So we draw a line that connects both these points. You can see this. So a line that connects both these points we draw, and we draw a normal vertical line and see the angle between these two lines. These two lines is the angle of Weber, and we see that how efficiently the head of femur can get fitted into the acetabulum in the frontal plane. Okay, we are able to see that how efficiently. Here this picture is a frontal picture. Okay, you are easily able to visualize the joint in the frontal plane. So we can see here that how efficiently that this head of femur can get articulated or get fitted into the acetabulum. Okay, acetabular cavity. So this line forms an angle with the vertical known as the center edge angle or the angle of Weber, and it tells us the amount of inferior tilting of the acetabulum. So the center edge angle can be classified as the normal range of center edge angle is between 20 to 25 degrees. That is what we were talking about. Okay. So if it is less than 16 degrees, so there can be dysplasia of the joint. Or if it is between 16 to, I would say 20 degrees, not 25 degrees, but still if it is between 16 to 25 degrees, there can be possible dysplasia. Or if it is normal or slightly greater than 25 degrees, then it comes to be normal. It's a normal joint. Okay. In addition, abnormality in the acetabular depth, inclination and version, abnormal positioning in the transverse plane can also be detected. That is the acetabular antiversion we'll be talking about. So this is the picture what I wanted to show it to you. This is an X-ray taken, and we have placed, or we have marked the center of the head of femur, and we have marked the acetabular lateral margin of the acetabular ring. Okay, and we have connected both the lines, and we have taken this angle from the vertical. So this has to be 25 degrees. Okay, 25 degrees is normal. Lesser than this, it can have displacement of the joint. Greater than this, slightly greater than this, can be better. But if it exceeds more than 28-30 degrees, then I would say there would be relative hypomobility at the joint. Okay, so it should be nearly between 22 to 25 degrees. That is a normal central angle. All right. Now, the second angle that we are talking about is the acetabular antiversion angle. Now, we have just talked about the fitting up of the acetabular of the femoral head in the acetabulum in the frontal plane. Now, this acetabular antiversion angle tells you that how efficiently the head of femur gets fitted into the acetabulum or acetabular cavity in the transverse plane. Okay, so for this, what do we do is, if you can visualize the picture, in the transverse plane, we take both the rims, anterior and posterior, take both the points and join both the points. Okay, now we take the angle of this line from the vertical line or the neutral line, and this angle should be nearly 20 degrees. All right. Now, this angle tells us that the extent to which the acetabulum covers the head of femur in the horizontal plane or the transverse plane. Now, it is the normal angle of acetabular antiversion angle is, normal value is 20 degrees, and it exposes the anterior aspect. See, I told you earlier also, the head of femur is covered more efficiently posteriorly by acetabulum, but it is not that efficiently covered anteriorly. Okay, so if you have greater angles of it, so the more of the anterior margins will be exposed, that I'll be talking about. That is the reason why we require more support or more soft tissue or ligamentous or muscular support anteriorly. We have iliofemoral ligament, we have pubofemoral ligament, we have iliopsoas muscle, which are strongly supporting the anterior aspect of the joint, such that it can be the anterior dislocation of this particular joint can be prevented. Okay, now thick anterior capsule, ligaments, and iliopsoas tendon gives an anterior cover. People with increased value of this joint are more susceptible to anterior dislocation of femur when going for anterior external rotation. See, when a patient is going for anterior external rotation, the spinning of this head will be in this direction. If there will be more spinning in this direction, larger surface area of the head of femur will be exposed outside, and it would eventually dislocate in this direction. Okay, that will be your anterior dislocation of the hip joint. Moving ahead, the acetabular labrum, another soft tissue which has a very good importance, or very much important with respect to the hip joint biomechanics. Okay, now the entire periphery of the acetabulum is a rim. It is a rim. It is a boundary that is being covered boundary covering of the acetabulum. Okay, it is a ring shaped and it covers most of the acetabular rim. Although it doesn't cover complete acetabular rim, but it covers most of the acetabular rim, as you can see it in the picture also here. You can see that this particular area is still left. So because it allows the entry of the base of the head of femur and at the starting of the neck of the femur also. So it deepens the socket, obviously, as we also know that a similar kind of structure is present in the shoulder joint also. It's called the glenoid labrum. Okay, it also helps in deepening of this. So now, you remember I told you in the starting that hip joint is meant more for stability but not for mobility, because it is geometrically more congruent. Okay, although it is geometrically more congruent, but still we require a labrum here so as to enhance more stability, the stability more of this particular joint. So why we require that? Because we have a transference of enormous amount of force that is coming from a head, arms and trunk. Because if we do not emphasize on stability of this particular joint, there could be some amount of injuries that would occur. because of abnormal distribution of weight that is coming from the upper body. All right, that is why we require more amount of stability at this joint, and this is what the acetabular labrum is concentrating on. Okay, now it enhances the joint stability, as I already told you, by acting as a seal to maintain a negative intra-articular pressure. I told you there is a negative intra-articular vacuum-like pressure being generated within the capsule. So it helps to enhance the negative intra-articular pressure. All right. It also provides some proprioceptive inputs and feedbacks. Okay. Although the labrum appears to broaden and the articular surface of the acetabulum, the experimental evidences suggest that load distribution in the acetabulum is not affected by the removal of labrum. See, if you can see this picture, you can see that the labrum is only associated on the margin. It is nowhere in the articular surfaces, right? It is nowhere in the articular surface. Okay, this is the articular cartilage. I told you the lunate surface. This is the lunate surface or horseshoe shaped surface, right? So it is nowhere in the zone of articulation. So if it is not there in the zone of articulation, the removal of it does not eventually affect the compressive loading, that is, or compressive forces which are lying between the articular surfaces of the hip joint. So there had been researches by Ferguson et al. That the hydrostatic fluid pressure within the intra-articular space was greater with intact labrum than without. So the negative pressure which is present inside the articular surfaces, it is more when the labrum is intact. But if the labrum is injured or if it is removed, the negative pressure eventually falls down. Okay, which suggests that the labrum may enhance the joint lubrication if the labrum is adequately fits. If the labrum adequately fits the femoral head, so it also helps in, rather than increasing stability or increasing the concavity of the acetabulum, it also helps in enhancing the lubrication. So along with stability, it is also giving you some amount of mobility. Okay, so you must concentrate on that also. Coming on to the distal articulating surface, that is the femoral head. So the first angle, without going into too much anatomy of the femoral head, I would directly jump onto the angle of inclination. So angle of inclination is again an entity of the frontal plane kinematics or the frontal plane biomechanics. Okay, so the angle that the head and neck, a line passing from the mechanical axis or mid axis of the head and neck, when it forms an angle with again an axis that passes through the shaft of the femur, that is your angle of inclination. Okay, it tells you that how much the head and neck of the femur are inclined in the frontal plane. Okay, so it is very easily being shown here, like this line. Okay, this is from the center of the head and neck. This is making a line angle with a line that is passing from between the shaft of the femur. So this is the angle that we are talking about. It must be nearly about 125 or 130 degrees, the normal range is about. The lesser the angle, it is called varus or the coxa vara. Okay, the varus deformity of the hip. And if this angle is increased, this it is called coxa valga, the valgus deformity of the hip. Okay. So with the normal inclination angle, the greater trochanter lies at the level of the center of femoral head. So if you can see here we have the greater trochanter and it lies somewhere at the level of the head of the femur. Okay. So the angle of inclination of the femur changes across the lifespan, being substantially greater in infancy and childhood and gradually declining to about 120 degrees in the normal elderlies. Okay. Pathological increase in the medial angulation between the neck and shaft is called coxa valga, that we've already talked about, and the decrease is called coxa vara. Another entity in the transverse plane, that the earlier was the frontal plane and this one is the transverse plane, is the angle of torsion. Okay, the torsion tells you about that how much the inferior surface or the inferior end or the distal end of the femur is rotated with respect to the proximal end. Okay, so the torsion angle of the femur describes the relative rotation that exists between the shaft and neck of the femur. Suppose I'm giving you an example with my handkerchief. See, because it is a flexible entity. Okay. So suppose this is the shaft of the femur. This is the head. Okay. So if the shaft of the femur, see, as we have already talked about that the head and neck lies at a certain angle. So if they lie at a certain angle, and if the whole bone lies at the same angle, in that case, the femur would be something like this. But we have distal articulations at the knee joint also. So we have to make a torsion. The body has to make a torsion such that it efficiently articulates with the knee joint also. So because of that, a rotation exists between the proximal articulating surface of, that is the neck and head of this particular bone, and the distal articulating surface that articulates with the knee joint, that is the condyle. So that particular angle in the transverse plane is known as the angle of torsion. So as viewed from superiorly, as you can see it in the picture also, the neck projects on an average of 10 to 15 degrees anterior to the medial lateral axis through the femoral condyle. This is called the normal antiversion. This area, this thing is called the normal antiversion. Physiologically also, there is some amount of antiversion which is present in the femoral shaft, or the angulation, or the angle of torsion is present between the neck and shaft of the femur. So that angle is about 15 degrees. So when I see superiorly, so this angle, the line that crosses the mid part of the head and neck of femur, and the angle it makes with the horizontal, sorry, this is the horizontal. So that particular angle is known as the angle of torsion, and the normal value is between 10 to 15 degrees. All right, this is called the physiological antiversion or normal antiversion. Now this 15 degrees of normal antiversion allows optimal alignment and congruence of joint. Now whenever this angle increases or decreases, that eventually has a very substantial or very significant effect on the geometry of the articulation of the hip joint. So the articulation disturbs, and one area is in more contact with the articular surfaces, the other areas are not. So it is more susceptible to increase in the pressure also, as we have learned in by the formula of pressure. So articulation area is reduced, so pressure will increase and more degeneration. It will eventually cause abnormal distribution of weight on the head, neck and shaft of the femur also. That would eventually try to cause some kind of fractures in cases of some trauma, or in cases of some abnormal weight distribution, or instantaneous weight distribution, or eventually they might lead to some dislocations also. Not even this, they would cause some contractures of some particular muscles which are getting shortened, and the muscles which are getting lengthened, they will cause some amount of reduced strength of that particular muscle. All right, so this degree allows you for optimal alignment and congruence of joint. The angle greater than 15 degrees, that will be called excessive antiversion, and an angle lesser than 10 degrees will be known as femoral neck retroversion. Okay, now what happens if it is in more antiversion or retroversion? So whenever a child is born, the angle of torsion for that particular child is 30 degrees. So if you see, it is double of that what we have in the adulthood. So eventually when the child starts walking, until the age of 6, he starts developing, or the angle gets reduced to 15 degrees. Okay, now excessive antiversion leads to congenital dislocation or marked joint incongruence and increased wear and tear. That's what I was telling you about. That is the early osteoarthritis. Okay, so whenever there is excessive antiversion, you can have dislocations, you can have joint incongruency, there will be more increased enhanced pressure, or will be enhanced compressive loading at some parts of the articular surface, that would lead to degeneration. Okay, now excessive antiversion in children may cause compensatory gait pattern also. So see, whenever the proximal superior portion of the bone is more antiverted, so the patient will have the inferior surface of that particular bone more inside or more rotated internally. So if the condyles will be more rotated internally, it would rather take the whole knee joint to be in internal rotation. If they'll have more internal rotation at the knee joint, whenever you place your foot while walking, the toe would direct internally. The direction of the toes would point internally. That is also known as the in-toeing gait. Or when the patient starts walking, they points the toe internally. That is known as the in-toeing gait. That could be because of exaggerated hip internal rotation. That is a compensatory hip joint internal rotation because of excessive antiversion angle. Okay. Now this gait pattern is a compensation of excessive antiversion that I've already told you, which eventually leads to contractures of the internal rotators. Because if the hip joint stays to be in internal rotation, the shortening of that muscle would lead to contracture of the hip internal rotators and eventually weakness of the external rotators also. In an adult, the normal angle of torsion is considered to be 10 to 20 degrees. Okay, coming on to the load bearing capacities of the bone. Now, walking and weight bearing produces tension. See, we have 5 forces that we talk about in biomechanics also, or in generalized physics also. So these 5 forces are tension, compression, bending, shear, and torsion. So all these forces are also applicable within the body also. Okay, so these are applicable within the body also, and so as on the hip joint also. So for the absorption of that particular force, the bone has evolved itself such that some areas are more susceptible to bear the tensile load. Some areas are more susceptible to bear the compressive load. We'll be talking in the coming classes. See, if the articulation of acetabulum is from here somewhere, the loading is coming from here. So if the loading is coming from here, this area will have tensile load or tensile forces. This area will feel, or this area will experience the tensile load. On the contrary, this area will have more of compressive load. This particular area will have more of compressive loading. So both these areas have different types of patterns of a particular bone, which has evolved because of the weight falling onto it. Okay, so by this we have divided the bone, or we have classified the bone in 2 types of the evolution of bone because of its formation. One is the compact bone and the other one is a cancellous bone. The compact bone is the hard bone, as the name suggests. So it is there in all the cortical regions. If you can see here, this area is a very stiff area that appears. You do not have any vacuoles or any air cavities from here. Right, so you have very stiffened areas on the sides. That is the cortical bone or the compact bone. Okay, they lies in the regions of femoral neck and shaft of the femur. Okay, they are those areas which are subjected to more of the larger shear forces and larger torsional forces also. All right. Again, at the center, there lie a cancellous bone, which is a soft, spongy sort of bone. Now, this type of bone or this type of bony tissue helps in more absorption of the forces. So you can see there is an arrangement of lattices, 3D lattices, as we see in the crystal. You must have seen the structure of crystal lattices. A similar type of arrangement we see here as in the form of bony lattices. Okay, or trabecular lattices. We call it as a trabecular network. Okay, this bone is relatively spongy and helps to absorb the external forces. Now the cancellous bone tends to concentrate along the lines forming the trabecular networks. Okay, now this area is also known as the arcuate trabecular networks, and this area is known as circular or complex trabecular network. Okay, so they have been evolved because of the demands which were imposed onto them. Okay, when I'm talking about demands, there comes one very important term which I want to share it with you. Okay, you people, do you know about Wolff's law? Anybody? You can write it in the comment box. Do you know about Wolff's law? What is Wolff's law? Just say yes if you know. I can see the comment box. if you know about the Wolff's law, you can tell me what is Wolff's law. Okay, Wolff's law suggests that the bone starts growing in the areas where the forces are being laid upon. If I am exaggerating, if I am giving a pulling force in some area, the bone will start growing in the direction of pull. Similarly, the formation of trabecular on the area of tensile and the area of compressive loading also follows the Wolff's law. Okay, so whenever you have more of the tensile loading on one area, you have different type of trabecular bone formation here. That is the arcuate trabecular bone formation. And the places or the sites where you have more of the compressive loading on the medial aspect of the neck of the femur. So on those areas, you have more of the circular or complex type of trabecular bone formation. All right. So always remember the Wolff's law. So it suggests you the bone starts growing in the areas where the forces are being laid upon. Okay. So this is one of the very important specificity or characteristic of the femur. Coming on to the articular capsule, although we have talked quite much about the articular capsule by now, articular capsule eventually covers the whole joint. It is there on the acetabular rim also, and it covers the whole head of the femur, having a negative intracapsular pressure, which sucks the joint, which sucks the head of the femur towards the acetabulum. That is why the dislocations of this joint is not that easy a task. Okay, so the articular capsule of the joint is an irregular dense fibrous structure with long and oblique fibers and with three thickened regions that constitutes three capsular ligaments. Okay, so you have a longitudinal capsular ligament also, you have circular capsular ligaments also. They are discreted in different areas. Okay, moreover, they lie over the anterior margins or the anterior regions, because we require thickened capsule on the anterior areas, because the acetabular rim is a little shortened on the anterior aspect. It is, as we have discussed, it is more on the posterior aspect, it is lesser on the anterior aspect. So anyways, the capsule is more thickened on the anterior aspect of the joint. So the capsule is attached proximally to the entire periphery of the acetabulum beyond the acetabular labrum. So the labrum is also intracapsular. Okay, that is why it helps in enhancing the negative articular pressure. Okay, now the fibers near the proximal attachments are aligned in a somewhat circumferential manner. Okay, it's surrounded, the joint is more over surrounded by the fibers of the capsule. Okay, the capsule itself is thickened anterosuperiorly, as I told you, where the predominant stresses occur. It is relatively thin. It is relatively thin and loosely attached postero-inferiorly, because you have the bony articular margin on that particular side. So you require lesser amount of soft tissue stability over there. Okay. The capsule covers the femoral head and neck like a cylindrical sleeve and attaches to the base of the femoral neck. So it inculcates the femoral neck also and femoral head also. Along with that, always remember you have a very high amount of negative intracapsular pressure, which sucks it in. Vacuum cleaner jasa pressure. The pressure which resembles the vacuum cleaner. Okay. So coming on to the other soft tissues of the hip joint are the ligaments. Majorly that we talk about, since we have already talked about the capsular ligament, that we have two capsular ligaments. One is the longitudinal ligament, one is the circular ligament. Along with that, we have three very thick ligaments of in the hip joint. That is the iliofemoral ligament, pubofemoral ligament, and ischiofemoral ligament. Okay, the iliofemoral and the pubofemoral ligament are the ligaments or the soft tissues that strengthen the anterior margins of the hip joint. On the contrary, the ischiofemoral ligaments lies on the posterior aspect of the hip joint. Okay, let us know about that. The iliofemoral ligament is like an inverted Y. You can see here the margin, the origin or the proximal attachment of the iliofemoral ligaments is superior to the acetabular rim, and it goes till your medial surface of the greater trochanter, and the other one is going posteriorly to the lesser trochanter, medial margin of the lesser trochanter also. All right, so it is making two different fibers. So we have two different fibers of the iliofemoral ligament, which is like an inverted Y, something like this. This is how it travels. Okay, so this is how the iliofemoral ligament travels. Okay, so this iliofemoral ligaments is also known as ligament of Bigelow, or the yellow ligament also it is known as. Okay, so as it is lying in the extreme anterior portions of the hip joint, whenever you go, the joint goes into extension, this ligament gets stretched and eventually it limits the extension range of motion. Anyways, we have very lesser amount of extension range of movement at motion at the hip joint. That also is being limited by iliofemoral ligament. And let me tell you one more thing, because of more higher concentrations of collagen in iliofemoral ligament, it makes the iliofemoral ligament one of the very strongest ligaments of the body. If you know, and if you don't know, I'll tell you that the people who are paraplegic, they use the tensile strength of this iliofemoral ligament to stand with the help of HKFO. All right, whenever they are wearing HKFO and while they are standing with the elbow crutches, the hip, this ligament stops or limits the hip to go into excessive extension. Okay, the tensile strength of this particular ligament limits the extension of the hip joint, which eventually prevents the patient to go into a backward fall. All right, that is why the tensile strength of this ligament is very important, and that is why I'm telling you that this ligament is a very, very, very strong ligament. Another ligament that we have to talk about is the pubofemoral ligament, that starts from the pubis and come onto the medial aspect of the line, intertrochanteric line, rather I would tell you. Okay, so it is also an anteriorly located ligament, and it is an anteromedially located ligament rather. So whenever you go into extension or abduction, it prevents both extension and abduction movements. Okay, coming on to the third ligament. Okay, there's one more thing written, that the bands of the iliofemoral and the pubofemoral ligament form a Z on the anterior capsule, similar to that of the glenohumeral ligament. Okay, so whenever we talk about them, they form a Z-like structure. So it is going like this, then the pubofemoral is coming like this, and this is again going like this. So they are making a inclined Z like this. All right, so this is what I've been told about these ligaments. Okay, now the last ligament that we have to talk about is the posterior ligament, that is your ischiofemoral ligament. It is also a ligament that blends with the capsule and strengthens the posterior aspect of the capsule. Okay, so although it is lying posteriorly, so it limits the flexion range of motion. At sometimes it gets stretched, I would say, rather, at the flexion range of motions, and also at the times of internal rotations. All right, coming on to the most important part and probably the last topic of the day, what we will be discussing today in the first part of the hip biomechanics is the kinematics. Let us start with the osteokinematics. As we've already talked about, that the degrees of freedom in the hip joint is 3. So the movement occurs in all the 3 planes, that is the sagittal plane, frontal plane, and the transverse plane. The sagittal plane movements are flexion extension, the frontal plane movements are abduction adduction, and the transverse plane movements are your rotations, lateral rotation and your medial rotation. Before I start anything, let us know about the close pack position. The close pack position for the hip joint is 20 degrees of abduction along with some amount of abduction and internal rotation. Although whenever we talk about the classical definition of the close pack position, it says that the close pack position must have the maximum articulation of the articulating surfaces. But in this case, we do not have maximum articulation. The maximum articulation is with the 90 degrees of hip flexion along with some abduction and external rotation. But in this position, all the ligaments are in their maximum tightened state, which eventually pulls the joint surfaces towards each other, or the articulating surface towards each other, increasing the some amount of you can say compressive loading at the hip joint. Okay, that is why 20 degrees of extension with slight abduction and internal rotation is considered to be as the close pack position of the hip joint. So talking upon the open kinematic chain or osteokinematics of the hip joint, in the sagittal plane we have 80 degrees of flexion with the knee extended and 120 degrees of hip flexion with the knee flexed. And the extension, as I've already told you about, it is 20 degrees of extension is present physiologically. Okay, frontal plane, we have abduction adduction. We have 40 degrees of abduction at the hip joint, which is limited by the pubofemoral ligament that I already told you, and 25 degrees of adduction is also present beyond the midline. Okay. Now in the transverse plane, we have internal and external rotation. The external rotation is about 30 and the internal rotation is around 35 degrees. Now for tomorrow, we have a lot of enormous great work to be done. We'll be talking about the closed kinematic chain, osteokinematics of the hip joint, that is pelvis on femur, when the femur is static and the pelvis is moving. Okay, so whenever the femur is static and pelvis moves, that becomes your closed kinematic chain, osteokinematics of the hip joint. So we'll be discussing about that closed kinematic chain. We'll be discussing about the muscular inculcations, the muscles, how the muscles are working, and what are the muscular specificities. And the most important thing, we'll try to take it up with the the analysis of forces also. So the 1 hour of tomorrow, probably a little more tomorrow, we'll have a power pack session of the closed kinematic chain motions, the muscular inclusions, and the analysis of forces. We have to see that how the forces are acting upon the hip joint, and along with that, the usage of cane on which side and how does the pressure on the forces changes along with that. So I'll not take much time of yours by now. Okay, so thank you so much, everybody. So if you have any questions, you can write it here also. Timing for tomorrow will also be same, 12. It will start at 12. So, okay, we have a question here. Can you please explain the differences between open kinematics and when the distal articulating surface is free to move and the proximal one is fixed, we call it as open kinematic chain. And whenever the distal articulating surface is fixed and the proximal bone is moved, we call it as the closed kinematic chain. Okay. Okay. Angle of torsion I have to explain. See, whenever I see superiorly and there is some amount of torsion का मतलब होता है, torsion means that the superior articulating surface or the superior aspect of the bone is at certain angle in the frontal plane or in the transverse plane, rather we can say that. Okay, तो होता क्या है, मैंने आपको पहले भी इसके थ्रू बताया था with this, that suppose this is a bone, if the normal physiologically, so as to improve the articulation of the femoral head with the acetabulum, some amount of antiversion, थोड़ा सा वो क्या होता है, आगे की तरफ rotated होती है, so as to get an easy articulation with the acetabulum. Okay, so it is a little torsioned anteriorly. That is, we call it as angle of antiversion. Okay, now in cases where they are more antiverted, the inferior surface or the distal surface of that particular bone is more torsioned in, or not really torsioned in, they have to rotate it so as to cause internal rotation of the hip joint, which eventually causes the internal rotation of the complete leg when we are going into stance phase or when we are going into heel strikes of the while we are into gait. So that makes the gait pattern to be an in-toeing, because at that particular time when the whole hip joint is in internal rotation, the toe points inwards. Okay, that is known as the in-toeing gait. Okay, I suppose you must be clear. Role of physiotherapy in hip joint replacement surgery. Okay, it is beyond the scope of this lecture today, but do tell this to me tomorrow. We'll be taking it by the end if we have time. Eventually, we have a lot of scope of physiotherapy after total hip replacement also and hemiarthroplasties also. So you have a lot of, see, we don't have function, we don't have muscle strength, we don't have proprioception there. So to induce muscle function, to induce joint function, to enhance the length to enhance the strength of the muscles there, to enhance proprioception, to enhance some amount of agility, we require physiotherapy. Okay. Q angle will be talking when we'll be talking about the knee joint, not today. How we manage the replacement surgery. See, I don't think we should talk more about the replacement surgeries here, because we are talking about the biomechanics of the hip joint. We'll talk about it in some other lecture. Okay, so then it means that sacrotuberous ligament and ligament of Bigelow both are the strongest. Sacrotuberous ligament is the strongest. I told you ligament of Bigelow is one of the strongest. Okay, it's not the strongest. After the sacrotuberous ligament is the second strongest ligament, I can tell you that. Okay, let me see if we have more questions over here. Hi, good morning, good afternoon. Eventually, tomorrow's timings are also, we'll start sharp at 12 tomorrow also. Okay, close kinematics we have done. Do we have more? We don't have more questions, I suppose. Force and distance. Force and momentum. What do you want to know about force and momentum? Jatin and Sapna. Okay, you have written. Okay. Sorry. You have written the answers. Okay, that's fine. Hi, good afternoon, everybody. Good afternoon. We are done with the session of the day. Great. So I think there is no more question. If still you have questions, you have my Telegram channel. You people are there in my Telegram channel. You are always welcome. You can ask questions. You can ask your queries. I'll always be there 24 hours to answer you people. And most important thing, I'll try to finish this biomechanics of hip by tomorrow. If not, we'll be taking one more session after this if we are not able to finish it tomorrow. But once I finish, we'll be having a quiz regarding the biomechanics of hip. So everybody, I request all those people who are listening to me, you must join the Telegram channel. We'll be having a great quiz in the Telegram channel coming up for you immediately after we finish the hip joint biomechanics. So I'm signing off for today. Thank you so much, everybody, for being there. I'll see you tomorrow, everybody, at 12. Thank you.